Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and today I'm back with our in-house toxicologist, Dr. Sanjay Mohan. Sanjay, good to see you.
Hey, it's good to see you, man. The sun is finally coming out, ready for the summer.
Absolutely. And well, the topic that we have is not necessarily a summer topic. This is a year-round topic. We can see it any time of year. It's one of your favorite topics, and one that I don't have a ton of familiarity with. So I'm happy and excited to get into it. That is hyperinsulinemia, euglycemia therapy in beta blocker and calcium channel blocker toxicity. Before we get specifically to the intervention, let's just do some basics. How are patients with beta blocker and calcium channel blocker toxicity going to present?
So it's probably a little bit of an oversimplification, but at the end of the day, both beta blockers and calcium channel blockers reduce intracellular levels of calcium within your heart cells, your myocytes. Depending on the degree of toxicity, effects will include decreased systemic vascular resistance, vasodilation, bradycardia, various conduction delays on the EKG, and then ultimately hypotension and cardiogenic shock. What that means clinically, you need to look for signs of poor clinical perfusion, acidemia, increasing lactate, decreasing urinary output, or even altered mental status.
I kind of put this together in my head as that odd combination of bradycardia and hypotension. There's not a lot of things that cause bradycardia and hypotension. Beta blockers and calcium channel blockers are clearly up there. We've both seen this. Blood in the belly causes this vagal response and can cause bradycardia and hypotension. Hypothyroidism is another one, but it's a short list. And so anytime you see that combination of vital signs, you got to think about beta blocker and calcium channel blocker toxicity. And we have been very specific to say toxicity and not necessarily overdose, because patients can have beta blocker and calcium channel blocker toxicity without having an overdose. And a lot of this has to do with kidney function and what else is going on. But just always keep it in your differential. Don't rule it out because the patient swears they only took their regular dose of their meds, because the regular dose can cause toxicity.
So I love this point, Swami, and I think it's appropriate to talk about as we transition to the next academic year. One of my favorite things to teach interns is tachycardia, bradycardia, hypotension, hypertension. What is the natural response to hypotension? It's a reflexive tachycardia. Recall that at the end of the day, cardiac output is a function of both your stroke volume and heart rate. So as you mentioned, when you see bradycardia or even relative normal cardia, for lack of a better term, in the context of hypotension, you should be worried. And to me as a toxicologist, the initial step should be to look at the medication list to see if there are any beta blockade or calcium channel blockers there.
All right, before we get to hyperinsulinemia, euglycemia therapy, let's hit some of the initial steps in management for beta blocker and calcium channel blocker toxicity.
So first and foremost, consider GI decontamination with our good friend activated charcoal, 1 gram per kilogram up to 50 grams. Keep in mind the patient must be alert or the airway must be secured as to avoid aspiration. Secondly, obtain multiple lines of intravenous access. And when I say multiple, I mean multiple, Swami. This is the patient that I want at least 2 or 3 peripheral IVs, if not a triple lumen catheter. And we're going to get to why later. When it comes to initial pharmacotherapy, there are 2 medications that I want everyone to think about. First, calcium gluconate, anywhere between 1 to 3 grams intravenously, or glucagon, 3 to 5 milligrams slow intravenous push. And just remember, some proportion of patients will have nausea and emesis with response to glucagon. If the patient doesn't respond to a judicious amount of fluids, the calcium or the glucagon, your next line should be vasopressors.
Is there a specific vasopressor that you prefer in this circumstance, or is it just our traditional, let's start with norepinephrine?
I think starting with norepinephrine is reasonable. At the end of the day, we want to get to our hyperinsulinemia therapy. So I think as long as you have a pressor that will bridge you there, I think that's okay.
All right, I know you're chomping at the bit to talk about HIET. Before we get there, though, how often does our basic supportive care work? Do we have any sense of how often that is adequate for the patient?
So this is a super complicated question, and I wish there was a straightforward answer. And this is kind of what makes toxicology, is that every patient presents differently. Some patients will do just fine with traditional therapy, get multiple lines, give it a liter or 2 of fluids, some calcium, some glucagon, and they may be able to ride that. However, some patients may remain refractory to standard therapy. They may be persistently hypotensive, worsening bradycardia, or even become altered despite your glucagon or calcium, or even pressors. At that point, I think you need to transition to hyperinsulinemia therapy.
Well, that kind of answers the question of what's the trigger for that hyperinsulinemia therapy. But do you have an idea in your mind? Do you have specific numbers that say this just isn't good, I'm moving to HIET, or is it that overall clinical picture?
Yeah, I think you just have to be a good bedside clinician. If the patient looks bad, they're not perfusing, they're not producing urine, worsening mental status, I think you've got to start to advance your level of care.
Here's one of the critical questions that we have to talk about with HIET. How does it work? I've asked this question to many people before, and there's a lot of hand waving. Sometimes I think that they're trying to figure out how to dumb it down for my small brain. But then I realize, you know what? I don't think everybody completely understands this. So, what is the mechanism here?
Well, good for you, Swami. You're going to get more hand waving today. So the mechanism is definitely not fully elucidated, but there's some, complementary theories. One is that insulin augments cardiac contractility by activating something called reverse mode sodium calcium exchange. That's really just a fancy way of saying that it increases intracellular calcium concentrations in your sarcoplasmic reticulum. Another theory is that at a resting physiologic state, the heart uses free fatty acids as its primary energy source. Under stress conditions, glucose is used instead. So giving insulin actually helps to facilitate glucose metabolism and energy utilization.
All right, my guess is that in a couple of years, we're going to have a different theory on how this works. So nobody out there has to memorize this unless you're a toxicologist or you're doing your fellowship in toxicology, in which case you have to memorize this and you have to know it forwards and backwards. But here's what I have to know. In the moment, when I am reaching for this therapy, how do I do it? What's the dosing? What are the logistics to make this happen?
Okay, this is really the nuts and bolts of everything. So the way I teach this is that DKA therapy, right? 0.1 unit per kilogram per hour insulin infusion. High dose insulin is 10 times that amount. It starts off with a 1 unit per kilogram intravenous bolus of insulin, and then you start the infusion at 1 unit per kilogram per hour. And then you're going to titrate every 30 to 60 minutes, keeping in mind that effects are not instantaneous.
So that means that we're starting with something like 70 units, 70 units as a bolus, and then maintaining the patient at somewhere about 70 units IV per hour as a continued infusion. Those are pretty massive doses.
Yeah, these are tremendous doses. And, one of the most important parts of this talk really is the logistic burden it takes to start this therapy. Because as you mentioned, Swami, you're going to tell your nurse you want to give a 70 unit bolus push of insulin, and they're either going to think you're crazy, they're going to laugh, or just walk away.
I've had this happen before. I've definitely had people look askance at me when I've said, yeah, I want 70 units. They're like 7. I'm like, nope, 70. So yes, you're going to have to be able to explain this, which is why we want to have a little bit of the background. I'm going to start that bolus. I'm going to start the infusion. At those high levels, I'm assuming I'm also going to have to get some dextrose with this.
Yeah, 100%. First and foremost, remember that if the glucose is less than 250 milligrams per deciliter, you should probably bolus dextrose beforehand just to make sure they don't become hypoglycemic. As always, if you're starting insulin, you need to be cognizant of 2 other things. The glucose concentration, obviously, but also potassium. Because remember, insulin will shift your potassium inside the cells and thus induce a hypokalemia. So once high-dose insulin is initiated, dextrose and potassium infusions should simultaneously be started to obviate both hypoglycemia and hypokalemia. More often than not, in a patient that I'm starting this therapy, I'm getting 2 to 3 peripheral IVs and likely a central venous catheter as well.
Yeah, I can't see doing this without a central venous line. I think you're also probably going to need an arterial line. So you're really going to need both of those to help to guide management. You can start with those peripherals, but at some point you're going to be throwing in a triple lumen because your nurses are going to be going crazy trying to hang all of these drips on different IVs. So just go ahead and put in the triple lumen catheter, put in the arterial line so you have good monitoring. So we're going to start the patient on that high dose of insulin, the 70 units as a bolus, 70 units per hour. And those are just starting doses because we're going to talk about titration as well. We're going to start the patient on a glucose bolus if their sugar is under 250 to start with. And then we're going to start infusions of both dextrose and potassium. How aggressive are you with those infusions? What dose are you using here?
Dextrose really will be anywhere between 0.5 to 1 gram per kilogram per hour via D50 or D20, which requires a central line in and of itself. From a potassium perspective, it has to be at least 3.5 or even higher. So as you can see, Swami, there are a lot of logistical roadblocks to resuscitating this type of patient. You need multiple lines of access. You need a pharmacist to help you with getting this insulin and infusing this insulin. You need your toxicologist and need your intensivist because obviously this patient is going to an ICU level. Keep in mind, These patients need an incredible high level of care. Finger sticks every 15 to 30 minutes, frequent potassium checks, probably an arterial line to make sure their pressures are at least stabilized, if not trending in the right direction. This is the type of thing, if a patient is sick, this could take up all your time in your resus bay.
Hopefully, this patient is going to move out of my emergency department to an ICU relatively rapidly. But you know how it is. Sometimes you get stuck with these patients longer. Maybe you have to arrange a transfer to another hospital for this patient. Once I've got all those logistics together, I've got the high dose insulin therapy going. How long is it going to be before it actually affects the patient? And then on the other side of this, how do I know when to stop the therapy? Because once the patient is stabilized and they don't need it anymore, we'd like to get rid of it and not have to do all of these other logistical issues that we have. So how do I know when to stop it?
So although these patients are incredibly sick, high dose insulin unfortunately does not work instantaneously. Keep in mind, it may be anywhere between 15, 20, or sometimes even 30 minutes before you start to see effect. So really you need bedside titration. When it comes to actually stopping high dose insulin, that's also complicated. At the end of the day, you want to see improving parameters of clinical perfusion, improving blood pressures, a reduction in lactate, improving acidemia, and even improvement in mentation. So really, it's a constellation of all those factors that should make you feel better at the bedside.
And you're definitely going to have your toxicologist looped in here to help you both to guide titration up of that hyperinsulinemia therapy, as well as titration down of that hyperinsulinemia therapy. Sanjay, before we wrap up, is there anything else that we need to keep in mind with management for this group of patients?
Yeah, there's something that I actually wanted to mention before. Most patients who are on beta blockers and calcium channel blockers, they tend to be on the elderly side. So naturally, they have poor cardiac function at baseline. That being said, I know ER doctors, and even myself included, love giving fluids up front. This is the one group of patients that I would be incredibly judicious when giving fluids, because I could tell you anecdotally, because if patients die from a beta blocker or calcium channel blocker overdose, they often die from fluid overload. These patients have multiple lines of multiple medications being infused. At the end of the day, the high volume of fluids will lead to pulmonary edema and renal failure, and they may actually need renal replacement therapy. A super stylistic point, but I think is incredibly relevant, is you could actually ask your pharmacist to concentrate your insulin to reduce the volume that you're giving patients. Standard insulin, I believe, is about 1 unit per ml, but you can concentrate that to 10 units per ml.
All right, fantastic. This is a great therapy for us to know about, to understand, but also to understand that we are going to need to get a lot of people involved to really make this happen. The ideal is, even though these are unusual cases, is to have a protocol put together. Have your toxicologist or the toxicologist that you use for consulting create a protocol that pharmacy has, that the ED has, that everyone knows about. So it's a little bit easier to institute. Someone's already signed off on it. So people aren't looking at you like you're crazy when you're telling them this, because we have something in place to make that happen. And while it is a little bit beyond what we are talking about today, there are patients who are refractory to hyperinsulinemia therapy. Those patients, there's not a lot we can do, but ECMO is one of those things. So you want to get this patient to a center that can do ECMO as part of their treatment, because they might have to go in that direction. And Sanjay, that brings us to the end of this particular podcast, but we want to wrap up with a couple of take-home points. So give everybody out there your big take-homes for hyperinsulinemia, euglycemia therapy.
Management of severe beta blocker and calcium channel blocker toxicity should occur in a stepwise fashion. Potential gastric decontamination, multiple lines of access, judicious fluids, calcium, glucagon, and vasopressors as needed. Initiation of high-dose insulin therapy requires a tremendous amount of logistical and cognitive resources, as it requires cross-disciplinary collaboration and is prone to mismanagement. Dosing, 1 unit per kilogram IV bolus, then an infusion starting at 1 unit per kilogram per hour infusion, and titrate every 30 to 60 minutes, keeping in mind that effects are not instant. Therapy requires simultaneous dextrose and potassium infusions, as insulin will induce hypoglycemia and shift potassium intracellularly. And lastly, if the patient doesn't respond to maximum pharmacologic therapy, venous arterial ECMO should be considered.
All right, that's all for the Rebel Core Content podcast this week. We'll be back in 2 weeks for another podcast. Until then, don't forget to check out all of the fantastic posts from our team. And until next time, stay safe.